I'm Dr. Manod from Sri Lanka. I'm Senior Registrar attached to National Hospital of Sri Lanka. And my case is the birth nightmare. I have no conflicts. So my patient is Mrs. J, a 59-year-old female, presented who had a history of type 2 diabetes for 10 years. This is casualty night, 11:30 p.m. Presented with central tightening type chest pain for 1 hour duration, with a pulse rate of 80, hemodynamically stable, and the saturation is normal. And this is the ECG, which showed acute anterior SC elevation myocardial infarction, and the bedside transthoracic echo revealed an ejection fraction of 40%. So we got the patient for primary PCI, and this is the cranial projection. You can see the proximal osteoproximal LAD. There's a 99% acute occlusion, and we proceed with our primary PCI, wired the lesion with a PTCA guide wire, and then pre-dilated with 2.515 semi-compliant balloon. Everything went well, no complications. Then we used to stent the LAD at 3.0 26 millimeter drug-eluting stent. We deployed the stent from the ostium. The only cranial projection is shown here, but we checked in all the orthogonal views and deployed the stent from the ostium. And this is the result after the stent placement. The flow is achieved. And then we started the post dilatation with a non-compliant balloon, 3.25 into 15. And we started from the distal edge, and we start post dilating. And if you pay your attention to this slide, when I post dilated the middle segment of the stent, the balloon ruptured. There was a gush of contrast, and then it was difficult for me to take the balloon out, and my guide catheter is getting sucked into the left main, to the proximal edge of the stent. Then I pull the balloon, and this is the subsequent scene. The balloon segment, the polythene segment was inside the stent, proximal stent. The patient complained of chest pain again, hemodynamically unstable, blood pressure crashed. We had to start on inotropes and put on oxygen, and the anesthetic is being ready. And now, as the Y is there, tried to balloon it subsequently, which pushed these balloon segments to medial AD. The proximal segment was okay, the stent was okay, but then actually no fracture. Balloon came out without the polythene part, the balloon itself, detached balloon.
Part of the balloon detached.
Yeah.
The LED.
Yes.
It's not fractured.
Not fractured. Everything came out except the polythene segment of the balloon. Just, yeah. So it pushed the balloon parts into the middle AD, obstructing the flow. So I did three things. I called my seniors, and then I alerted the cardiothoracic team, and I looked for an intracoronary snare, which was not available at that time in my cath lab. So I tried various things. I tried aspirations. With a the guide extension. Tried to pass a stent beyond this balloon segment. Everything failed. Then, with the help of a microcatheter, I passed 3 guide wires. 2 went across the balloon segment, but the third one did not. But still, then all 3 guide wires into one snare, one torque, and twirled everything and pulled everything out, which improved the LAD flow. But still, there was no change in the position of the balloon segments. Then again, with the help of a microcatheter, put a cyan blue wire, and then exchange it into a extra support wire. And then I was able to pass a short stent across below the obstructed balloon segment. Then I gradually pulled everything up to the distal edge of the previous stent, and there I deployed the stent, and this is the result. So I prepped the trap the balloon material.
Crush it against the wall?
Yes, crush it against the wall.
Why not just put in the other wire,
Yeah.
balloon,
Mhm.
small balloon, and inflate it?
I tried that. It didn't come. It was stuck at the distal end of the previous stent. Yes, yes. I tried that, but the balloon segments stuck at the distal edge of the previous stent. That's why I had to crush it against the wall. Yes, with a stent, I crushed it against the wall. At this point, at the midnight, I didn't have access to intravascular imaging, but I got down the patient 2 months post procedure, and this is the result and the intravascular imaging at that point.
The other option,
Yeah.
I'm just thinking now, is to push it very distal in the one of the distal apical branch,
Okay.
and leave it in the very distal AVD.
All right.
We can keep the discussion to the end, but let him finish because we are running out of time.
All right. Okay. So the learning points are the retrieval of foreign objects detached inside coronaries can be extremely challenging, and the availability and use of intracoronary snares will help in these challenging circumstances. And the use of intravascular imaging is beneficial, and the place of and this patient, as there's foreign material that we have crushed against the wall, we put her on triple therapy for 1 week, then the dual antiplatelet therapy. So a place of antithrombotic therapy in addition to dual antiplatelets in these circumstances should be looked into, and cardiothoracic surgical assistance is required. They were standby at this case. So thank you very much, and I would like to thank Dr. Anidu Patiran and Dr. Bhati Ranasinghe, who are my trainers and who helped me with this case. Thank you very much.
So, thank you.